Hello and welcome to a special interview for The Wire supported by Glenlivet Books. Today we focus exclusively on the AstraZeneca vaccine and the Delta variant. AstraZeneca, as you know, is called Covishield in India and constitutes 88% of all vaccination given in the country. The Delta variant is rampant in India. India has more cases than any other country and arguably more than all countries in the world put together. Those are the two subjects I should raise today with Professor of Pediatric Infection and Immunity at Oxford University, the Chief Investigator of the AstraZeneca vaccine, and the Director of the Oxford Vaccine Group, Professor Sir Andrew Pollard. Professor Pollard, after studies by Public Health England established that a single dose of the AstraZeneca vaccine, known as Covishield in India, provides 30% protection against symptomatic illness caused by the Delta variant, the British government moved pretty quickly to reduce the gap between two jabs of AstraZeneca to 8 weeks, first for people over 50 and vulnerable, and then more recently for people over 40 as well. Now, given, as I said in the introduction, that AstraZeneca is 88% of all vaccination in India, and given that the Delta variant is rampant in the country, would you advise the Indian government to similarly reduce the gap between two AstraZeneca jabs to 8 weeks?
Well, I think the first thing that we should look at is what we're trying to achieve through a vaccine program, as you have in India. And the key thing we're trying to achieve is a reduction in the pressure on the health systems, hospitalizations and deaths. And the vaccines, including Covishield, have very high levels of protection against that endpoint. With one dose, the most recent Public Health England data is around 67% protection against hospitalization with a single dose. And if you get to 2 doses, it was over 90% protection. So I think focusing on symptomatic infection is it's sort of a problem going forwards, because the Delta variant, as you said, the latest data says there's about 33% protection against symptomatic infection. And so that's sort of mild disease that happens in the community. And future variants, we would expect for all the vaccines, for that endpoint to become much, much harder for the vaccines to work against it. But the key thing is that delinking of that community infection from the severe disease and hospitalization, because if we can delink the two through vaccination, then we start to curb the pandemic. And the whole reason why the world is in such a difficult state is because of that pressure on health systems.
I completely accept the point you're making, that in terms of serious illness and hospitalization, after one jab, AstraZeneca confers 67% immunity, and after 2, I believe it's 91 or 92. But I'm actually talking specifically about immunity against symptomatic illness, because let's be honest, when the British government acted to reduce the gap to 8 weeks, it was on the basis of that 33% figure regarding symptomatic illness. And therefore, my question is, in terms of reducing symptomatic illness, should the Indian government follow what the British government has done and reduce the gap to 8 weeks, particularly since this is our main vaccine and Delta is rampant in India?
Well, I think you're asking me a political decision, which obviously the Indian government has to make.
No, I'm asking you a decision as a vaccine scientist and what you believe as a vaccine scientist would be the right thing to do.
But that's where I'm sort of trying to give an answer about that, which is the critical bit, which isn't about symptomatic infection. Now, if you are in a situation like we are here in the UK, where there is very high coverage already, there isn't a supply problem for our much smaller population than you have. There are nuances about giving second doses a bit earlier so that you get higher levels of high protection sooner, and you might even reduce some of the spread if you do that. But it's a very different situation at this moment in India, where the main issue is having enough supply to cover the very large population of India to get the maximum benefit. And the maximum benefit is by getting that first dose into as many people as possible to reduce hospitalizations and deaths.
There's 2 questions that arise out of your answer. First of all, are you questioning the decision made in your own country to reduce the gap that was made with Delta specifically in mind? And it was made after PHE said that protection against symptomatic illness was just 33%. In fact, that figure of 33% has more recently been brought down to 30. So are you, first of all, questioning the decision made by the UK to shorten the gap? There's a hint of that in your answer. I just thought I'd clarify.
No, not at all. Because as I was saying, there's a very different situation here where there is plenty of supply. And so bringing the gap down in order to then have higher levels of protection against symptomatic infection, and also, as we've just discussed, higher levels of protection against hospitalization, makes absolute sense. It's all geared towards how do you get the best control domestically in a setting where there's plenty of supply. That is a very different situation from many other countries where that high levels of supply are not yet present, in which case the absolute priority must be to save lives.
In which case, the implication that I infer from your answer is this. If you have sufficient vaccine, it might make sense to reduce the gap in India in the present circumstances. But if there's a shortage of vaccines, it's advisable to ensure that you give everyone the immunity conferred by one jab and therefore extend the gap. And that may be preferable when you have Delta staring you in the face. Have I understood that second inference correctly?
It's actually a very complicated answer that's required here, because shortening the gap may confer exactly that benefit of, if you've got plenty of supply, getting 2 doses in a little bit earlier does have the advantage of higher levels of protection. But the other nuance there is that having an extended interval between the doses actually gives higher protection after the second dose. So there's a bit of a trade-off that if you have a much longer gap, then you might get slightly higher protection after the second dose. And if you reduce to 8 weeks, you get your second dose in a bit sooner, which is important to get the overall higher levels of protection, but you may lose a little bit in the total level of protection. So it's a trade-off between the two. And we've seen from the clinical trials that 3 months is better than 1 month. So reducing to 1 month has less immune response than at 3 months. So there's a bit of a trade-off.
Let me sum up the position like this. You know, and I know that the Indian government will be watching this interview. You know, and I know that your peers in the Indian scientist community will be watching. And they will, I suppose, interpret your answer to mean that you are not willing to give advice to the Indian government because it's a complicated matter. And you can see the logic about extending the gap. And at the moment, given the circumstances of vaccine shortage in India, it might be more sensible to keep the gap extended rather than to narrow it. Would that be?
Well, that is absolutely clear. The data on this are absolutely clear that if you have a vaccine that has more than 50% protection against severe disease, it is always better to get the first dose into more people than to give selfishly second doses to a smaller number of people. So it is absolutely the case that having more people vaccinated protects many more people against hospitalization and death than if you don't vaccinate the population. Zero vaccination is not a good situation to be in.
That is clearly an almost endorsement of what the Indian government is doing. Let me put something else that the Indian government has said, which reflects upon the position in the UK. When the Indian government announced the decision on the 13th of May to extend the gap up to 16 weeks, it said, and I'm quoting from their official document, that they were doing so because of what they called real-life evidences, particularly from the UK. Can you tell me what real-life data does the UK have that justifies extending the gap to 16 weeks? As I understand it, the original UK position was to extend it to 12 weeks, not 16. So do you have evidence that covers an extension from 12 to 16?
Well, there's 2 components to this. One is how long does the protection with 1 dose last? And the protection with 1 dose is extremely good up until 12 weeks. We've got evidence from the UK, we've got evidence from the clinical trials showing that. And it doesn't fall off a cliff. There's the way that immunity works is it doesn't suddenly disappear magically between 12 and 16 weeks. So it is quite reasonable in the context of supply shortages to have a longer extension. The other thing that we do know is that having an interval of somewhere around 12 to 16 weeks, you get better immune responses after the second dose than you do if you have short intervals of 3 or 4 weeks. And so for that reason, there isn't harm by having the extension, in that we don't expect to suddenly lose all protection by that extension. And even more importantly, you still get really good responses after the second dose. So you're not compromising people when you do have enough supply to get the second dose in.
Okay, you're saying two things there that I'm just repeating so the audience can bear it in mind. One, the extension up to 16 weeks is quite reasonable. And secondly, there's no harm in doing so. Let me come to something else that was brought out by two separate studies, one done by Public Health England, another done a little earlier by Public Health Scotland. Both of them have concluded that 2 doses, I'm now talking of 2 doses of AstraZeneca, confer 60 and 67% protection, respectively, against symptomatic illness caused by Delta. And that's comparing to roughly 79% and 88% for Pfizer. And most people notice that that's a very substantial difference of 19% or 21%. Is this a problem for countries where AstraZeneca is the main vaccine and they don't have access to others like Pfizer and Moderna?
Well, I think there's 2 components to answering that question. The first is that we don't know what the final figures will be, because there are some differences between the populations in the UK who've had each of those vaccines. We're giving a lot of Pfizer doses to the younger people in the UK who may have better protection anyway. And secondly, the period of follow-up is slightly different. And Public Health England have made this clear that it's a bit too early to conclude that those differences are real. I mean, of course they could be, but we do need more time. It's still pretty early with the studies in the UK to be sure about whether the immunity will build some more with either the AstraZeneca or the Pfizer vaccine, to be sure whether there's a real difference or not. But the second point here is that this is the Delta variant, and we've seen a bit of a drop-off in protection from when compared with the Alpha variant, which we had circulating here in the UK from December. If we wind the clock forwards, future variants will be much better at escaping from vaccines, from all of the vaccines, because that is the natural evolution of the virus. And so if you focus on symptomatic infection, we can make a prediction that percentages will start to drop over the months and years ahead. But the critical thing, as I come back to my point earlier, is we need to look at hospitalization data. And as long as that maintains at the very high levels of protection we're seeing at the moment, we are going to be in a very good place. So as I say, I think symptomatic infection is useful to do at this stage in the pandemic. It gives us a handle on what's happening, a bit on escape, but it's not actually the really important exam question. The important one is, are we still sustaining protection against severe disease?
Once again, I'll pick up on the 2 important things you said to the audience. One, these are not conclusive findings. They could change when you get more and better findings. And secondly, these are focusing on symptomatic infection. And the main thing actually is not to focus on the symptomatic quality of the protection, but on whether it protects from severe disease and hospitalization. And the third thing you said is, as more variants come, their capacity to escape the vaccine will increase, and therefore don't focus on the symptomatic infection, because that may actually diminish. Focus on the protection against ill health and hospitalization, which is the important thing that keeps you alive.
Exactly. And of course, at this moment, we're talking about the Delta variant, and we've seen the vaccines give really good protection against severe disease with Alpha, Beta, Gamma, and now Delta. And as long as that is sustained as we work our way through the Greek alphabet, and then we're in a good place in the pandemic. I think another really important thing just to reflect on is that coronaviruses are very common in human populations. Most of us have met them repeatedly as children. As adults, every 5 to 7 years, we will get a head cold with those same coronaviruses, and we live with them perfectly happily. If we were focusing on those minor symptoms that we get as adults, we would be getting very worried about the normal coronaviruses that we get in populations normally. And I think that's the key here is, and we don't know this for certain, but with this virus, if indeed that is how the future looks, that we have a virus just like the other coronaviruses that circulates and doesn't cause severe disease, we can live with it. But what we need more data on is whether that break that we're seeing between symptoms and severe disease continues, or whether there are future problems still in store.
That's a very telling point. The symptoms that we're focusing on actually are no worse than a bitter fever and a head cold. And we have that anyway quite often during winter. Don't focus on it. Concentrate instead on protection from severe disease. In the context of that answer, let me give you a chance to respond to some points made by leading scientists who I imagine you know in India. I'm quoting just one. The chairman of the Indian COVID working group, Dr. N.K. Arora. I believe you know him because in an interview he gave me 3 weeks ago, he spoke about you. And in that interview, he said Pfizer was a more superior vaccine. He said AstraZeneca was less potent. How do you respond to that sort of comment by a person like Dr. Arora?
Well, if you look at the levels of neutralizing antibody that are produced by the two different vaccines, the Pfizer vaccine does induce more neutralizing antibody. So in that sense, you can say that there's more potency. But the critical point is not about the level of neutralizing antibody, because that is what the virus is escaping from. So as I say, as we wind the clock forwards, the issue is going to be about prevention of severe disease. And as you'll have seen in the Public Health England data, both vaccines are giving over 90% protection against severe disease, even with the Delta variant. So I think that tells you that the mechanisms that we have to protect ourselves from the infection in our lungs that gives the severe disease are not the ones that we're measuring that are relevant for symptomatic infection, and also that potency test that you just mentioned.
Professor Pollard, I want to now move on beyond India and the specific questions to do with India. But let me underline for the audience the one important thing you said at the beginning, which I think you repeated many times, that in the present circumstances, it is probably more sensible to ensure that a wider number of people get some level of immunity through one jab, rather than worry about giving 2 jabs to a smaller number, because even one jab, after a delay of 3 months, can provide very high levels of protection. And it's really protection against serious disease and hospitalization that one should worry about, not the fact that the protection against symptomatic illness may not be great. Now let me come to a problem you really face in Europe, not in India so far at all. And that's the fear or the concern that AstraZeneca can sometimes lead to rare blood clots along with a low platelet count. And as you know, as a result, several European countries have imposed age bans below which they are reluctant to give AstraZeneca. I believe in Iceland, they don't give it to people below 70. In Sweden and Finland, they don't give it to people below 65. In Germany, Italy, and Spain, they won't give it to people below 60. They won't give it to people below 55 in France, and even in your own country, they won't give it to people below 40. How do you respond to these age bans and this concern that AstraZeneca could lead to these very rare blood clots with a low platelet count?
Well, this is about risk-benefit. And so there's an association which is now well recognized in some populations between vaccination and these very, very rare events. So if you're in a setting where COVID is raging, then the risk from the coronavirus infection is so high that that risk-benefit calculation changes so that it makes absolute sense. In fact, in many populations around the world, unfortunately, at this moment, there's so much circulation of the virus that in any age group, having the vaccination, the benefits of having the vaccination far outweigh any risks. But if you come to populations with very low rates of disease and very good control of spread, then that balance of risk and benefit changes. And because of a slightly higher risk that's been noted, and particularly in Europe, in younger age groups, that risk-benefit balance is different if you're in your 20s and 30s than if you're in your 60s. And so where we are in the UK at the moment is the cutoff for the use of the vaccine is at the age of 40. And it's very clear from the analysis that's been done, if we had a huge wave of disease and a lot more cases causing severe disease in young people, then that risk benefit would change again and it would make more sense to use it. So it's very much dependent on the circumstances at the time, balancing up the risks and the benefits. We've had such a low rate of disease in recent months that you end up with things being very finely balanced between a very rare risk of blood clots and also a very rare risk of infection with the virus. And so you have to make that judgment call. But as I say, that could change.
One of the corollaries of your risk-benefit analysis answer is that European governments have access to other vaccines like Pfizer and Moderna, and so they can afford not to use AstraZeneca for a particular age band. But in many countries of Asia and Africa, not only is AstraZeneca the most affordable vaccine, but it's also the easiest to handle, both because of its temperature requirements and its other logistics. Are you worried that over a period of time, and this could actually happen quite soon, AstraZeneca could begin to look like a third world or a poor country vaccine?
Well, the vaccine has been incredibly widely used across Europe. It's the main vaccine that's been used here in the UK. So from that perspective, I don't think that's very likely. It's being used in many other countries as well, in high-income countries. And as far as the situation in India is concerned, as you said, there have been very few reports of this very rare condition in India. We don't know why that is. But if there are differences in different populations in the risk of this condition, then that immediately changes that risk-benefit analysis. And it makes absolute sense to be using a vaccine that's available and deployable in the way that you've said.
Tell me something, Professor Pollard. Why has AstraZeneca not got authorization in America? At the end of March, we published very credible phase 3 results, which showed 76% immunity against symptomatic infection and 100% against serious illness and hospitalization. On those grounds, one would have thought AstraZeneca would be immediately accepted and cleared by the American government, but it hasn't happened. Why do you think that's the case?
Well, I don't know the details of the discussions between the FDA and AstraZeneca, but the vaccine is currently deployed in over 170 countries. Somewhere around 100 regulators have looked at the data and are very satisfied with it, including many competent regulators here in Europe, in India, in Australia. And so I think it's difficult to understand why there is a delay in the United States, but that's something you'd have to ask AstraZeneca or the FDA.
Before we end, let's look a little forward. There's a lot of talk that booster jabs or third jabs might be required, and if the press can be believed, your own country, Britain, is considering giving a booster either sometime late autumn or early winter. And my question is a simple one. If boosters are necessary, can AstraZeneca, an adenovirus vector vaccine, be useful?
Well, I think the first thing to say is that we do not know whether boosters are needed. We so far have not seen declining protection, but it's so early. The rollout here in the UK only started in December, so we haven't really had enough time to see whether protection starts to decline after vaccination of a large population. From the clinical trials, up to about 6 months after the vaccines have been given, we didn't see any decline in protection. But of course, we need to be able to look further forward into the months and years ahead to know whether boosters are needed for waning immunity. The other possibility for boosting is if we needed it for new variants, if they started escaping in a way that led to more hospitalizations, you might need to boost for that reason. But we do not have the answer to either of those questions yet. And so it's, in my view, it's not possible to make a scientific decision about boosting. So where the...
Sorry, carry on. My apologies.
No, I was just going to say that we need some more time to answer the question of whether boosters should be used. Your question specifically was about whether viral vectors can be used for boosting, and there's absolutely no reason why they shouldn't be, and we will publish some data on that, hopefully before too long.
I'm not a scientist, but the reason I ask the question is because there's a certain concern that your vector vaccine may lose potency with repeat injections because the carrier virus may encounter immunity against itself. Does that mean that if boosters are necessary, AstraZeneca may not play a useful role at that stage? Or do you think this is too early to make this judgment call?
Well, we know from previous studies that you can give boosters with viral vectors, so I don't anticipate that to be a problem. But as I say, we will publish some data on this fairly soon. I mean, certainly the concern that has been raised is about whether having some immunity against the viral vector might reduce the potency of a boost. But we haven't seen any evidence of that in the clinical trials, that when you give the first dose, you get induction of antibodies against the viral vector, but that doesn't compromise the response to the second dose. So there's no reason to think that with third doses that would be the case either. As I say, we will have some data very soon to demonstrate that issue.
Now, in the interview he gave me on the 28th of May, Dr. N.K. Arora, the head of the COVID working group, revealed that he thinks there's a real possibility of a single-dose AstraZeneca vaccine being introduced before the end of this year. And I want to ask you, is this something you're working on in Oxford, or is this something that's happening separately with the Serum Institute in India?
Well, I think as we've seen in the data from Public Health England, that to have the highest levels of protection against hospitalization, then 2 doses are needed. That gives much better protection. So I think the point is 1 dose can be extremely good at controlling the pandemic. But so far, the evidence, to my mind, looks as if 2 doses are going to be much better at protecting people from severe disease. So we're not working specifically on a 1-dose strategy here in Oxford. I think we see the data emerging suggesting that 2 doses will optimize protection in the long run.
That's a very important answer for the Indian audience. You in Oxford are not working on a 1-dose strategy for AstraZeneca. And secondly, you believe 2 doses are better than 1. In other words, you don't know from where Dr. Arora has picked up the belief that a 1-dose AstraZeneca called Covishield in India could be a possibility before the end of the year. That's news to you.
Well, I think that the data that we discussed at the beginning of this interview showing good protection with 1 dose, but against hospitalization, but you can enhance it further with a 2nd dose. Given that we've got large populations around the world who are over 50 years of age and are at risk of severe COVID and hospitalization, we really do want to maximize the protection we can get with the vaccines. At the moment, that looks as if 2 doses does the best.
Now, newspaper reports have said for a while that AstraZeneca is experimenting with what's called a mix and match policy. There have been reports of combining AstraZeneca with Pfizer and separate reports of combining AstraZeneca with Sputnik. Can you tell me how far has this experimentation got? And is it meeting with some measure of success to encourage you?
Well, we're not experimenting sort of direct, or sorry, when I say we, AstraZeneca are not experimenting directly, but there are a number of studies, including some led from here in Oxford, looking at different schedules of mixing and matching vaccines, both for 2nd doses and even for 3rd doses, to try to see whether we can get good responses by doing that. And with many different vaccines, it's not just with Pfizer, but with a whole variety of other vaccines. And I think the data from these studies can be very helpful in countries where there are supply shortages, and to be able to work out whether, if there was interruption of supply of 1 vaccine, you could then switch to another one. So they're going to be very important studies to answer that question. It's not that there's a specific policy need to have different vaccines for the 1st and 2nd one. It's more about having a look at the different options that could be available to countries in the future to maintain protection in the population.
What I hear from you is that a policy of mix and match or experimenting with mix and match makes a lot of theoretical sense, but as yet, you don't have a conclusion about whether it's viable, and you're far away from deciding that a combination of A and B is a better combination. This is still at an experimental stage.
Well, the clinical studies are underway that are being funded by the UK government, and there are many of those running at the moment, or many different arms to the studies running at the moment. So we will have more data very soon on those mix and match options. But if we come back to the science, most of the vaccines that we're deploying around the world are based on spike protein. And our immune system, if you give one dose of spike protein, will remember that. If you give another dose of spike protein, whichever the vaccine is, you should get a boost. So the mix and match schedules should work. And this is really a question of just checking that and being able to provide the data to policymakers so that they can make decisions.
My last issue. As you know, Professor Pollard, the Delta variant has now mutated and become what's called Delta Plus or AY.1. It's also officially known, I believe, as B161721. And it's reported that this contains the K417N mutation, first identified in the beta variant found in South Africa, which is said to be both more infectious, but also possibly more resistant to vaccines. In your eyes, as a scientist, is Delta Plus a matter of concern, or is it too early to come to that conclusion?
Well, I think you're right. It's too early to come to the conclusion. We need to have real data to answer that question. It hasn't been totally predictable when new mutations arise and how that will impact on vaccine protection. But the important point to come back to our earlier discussion is about whether these mutations result in escape in the way that we would predict is going to happen in the future, so that you get more symptomatic infections, more transmission. If the vaccines still protect against severe disease and hospitalization, we'll be in a very good place. And those are the really important data that we absolutely need to know with each new variant as it emerges. Do we maintain that degree of protection?
This would be very reassuring for the audience. So I'll repeat it in layman's language. What you're saying, as more and more mutations and variants come, and they're inevitably going to come, don't worry about increases in symptomatic infection. What matters is if the vaccine can still hold good in terms of protection against serious disease and hospitalization. And so far, we believe the vaccines do hold good in terms of protection from serious disease and hospitalization. And therefore, don't worry if symptomatic illness increases. That's common colds, fevers, etc., which happen anyway.
Well, I think you're absolutely right how you've just described that. The problem is if you've got a population that's largely unvaccinated, which of course is the case in many parts of the world. So a virus which spreads more readily in a population who are unvaccinated means that it will find those individuals who are susceptible to severe disease. And so really the urgency is to get at least one dose to as many people as possible, as soon as possible. And that's a global problem that we have. It's not just a problem in India, it's everywhere that we need to do that.
But that last answer, once again, seems to endorse what the Indian government is doing. Because as you said, if you have a large population that's unvaccinated, the urgent need is to get at least one jab to as many people as possible, as quickly as possible. And therefore, if you do that by extending the gap, particularly in the face of Delta, it makes sense to extend the gap and ensure many more people have one jab. And once again, that is an endorsement of what the Indian government's doing. It takes us right back to where we began, but I'm just underlining that for the audience.
Yeah, I think you're absolutely right in that view. The other thing is that to focus when there's a shortage of supply on those at greatest risk, and that's the oldest adults and also those who've got other health conditions. So that would be my priority at the moment, is first doses into those who are most vulnerable.
My very last question. When we were talking about Delta Plus, you said, as yet, it's too early to consider it a matter of concern. We need better and real-time data. Now, on the 11th of June, Public Health England reported that of the 36 Delta Plus cases found in Britain, 27 occurred in people who had taken at least one dose of vaccination. To me, a layman, that sounds like 75% of all breakthroughs. Is it worrying, or is it just too small a base on which to get worried?
Well, I think it's both too small a number, but also, again, that's symptomatic infection. We need to know about hospitalization as the absolutely critical component of this, because if we still, despite having a bit more spread in vaccinated people, have no one going into hospital, then we've had that huge impact that protects us and our health systems from the virus.
Professor Pollard, thank you very much for the time you've given me. Thank you very much for patiently answering all my questions. And once again, I'll repeat the most important thing that I believe you have said as far as the Indian government's vaccination policy is concerned, that when you have a large population that is unvaccinated, faced with the threat of the Delta variant, it makes sense to ensure that as many people as possible get at least one jab as quickly as possible. And that, in a sense, justifies a longer gap between the two jabs, rather than shortening the gap and limiting the protection, even though it may be better in quality, to a fewer number. I think I've summed you up correctly, but would you confirm that or not?
Absolutely. Get vaccinated, but focus on the over 50s and those with health conditions.
Thank you very much indeed, Professor Pollard. Take care. Stay safe.
Thank you.